All right, why don't we go ahead and get started? As more people join, we have a good quorum now. As more people join, we'll let everyone in. So thank you everyone for joining. It's a real pleasure to be here today to kick off this, our second webinar of the series titled Scaling Virtual Cardiology. My name is Jeff Wessler. I'm a cardiologist and the CEO at Heartbeat Health, which is a virtual cardiology company. We've been around since 2017 and seen a really incredible year this past year as virtual care and virtual cardiology has taken off. And one of the reasons that we've been so excited to begin this webinar series and these sessions is really, we've seen so much interesting work happening in the cardiology space as it relates to digital health and virtual care, but found that there haven't been so many people are doing interesting things, but they're not getting shared to the world. So we want to help make sure that the amazing practice habits and creative ways people are using virtual care are shared, made available, and that we start a dialogue to make sure that we as a group and as cardiologists can help protect the way virtual care moves forward and make sure that it flourishes. So with that, I'm really excited to join this webinar with three cardiologists, Reshmaal, Gomes, Andrew Freeman, and Ankit Bhatia. I'll have all three of them give a brief introduction where you can say where you're from, where you practice, and then maybe just a 30 seconds or so about the status of virtual care in your practice habits, since each of you work in very different settings, which I think is going to be really exciting. So Reshmaal, I'll kick it off to you to start, and thanks again for joining.
Hi everybody, thank you again for inviting me. So my name is Reshmaal Gomes. I am a cardiologist who does non-invasive cardiology. I'm in a private practice setting in a group of about 15 providers. Virtual healthcare was new to us, and the pandemic is what that brought that to a head to us. And at the beginning, it was a challenge, and that's a challenge for us as providers. It was a challenge for my patient population as a group, and also to our support staff. Challenge to the providers was a mix. It's mixed because we were all from different times in our careers and what we felt was comfortable in doing. And one of the biggest challenges was there wasn't going to be an exam in the patient care. And for all of us from the time of med school, it was history, examination, and then you come to a decision. So that had to be crossed for all of us. And patients, again, there was boundaries that had to be broken with them. Face-to-face was so important to them on one-on-one. But as time went on, when the providers and the patients realized that not only were we protecting them from COVID exposure, but the providers themselves were getting less exposure. Plus, most importantly, their care was going to happen. Their care for prevention was happening with virtual care, and their care for ongoing medical problems that they were aware of was being controlled. And we really felt that we were making progress in limiting their hospital admissions. And these are for the patient population that was terrified for going to a hospital admission because of COVID. So it's come a long way since we first started last year, but I think we all have some ways to go yet.
Fantastic. Thank you for that. And yes, welcome again. Andrew, do you want to intro yourself and walk us through your practice environment?
Sure. So my name is Andrew Freeman. I'm a cardiologist, also non-invasive and prevention-oriented. I work at a National Jewish Health in Denver, which is sort of a tertiary quaternary referral center where we see some of the strange stuff. And also Colorado is situated in such a place that a lot of people live right at the edge of the mountains, the so-called Front Range. But then we have a lot of people who live in the nooks and crannies of the mountains. So telehealth has been incredibly helpful. And I would argue is here to stay, right? If you asked me to take a snowy single lane pass to drive to National Jewish versus say, roll out of bed and start my phone, I think I would choose the phone. And I think a lot of people are starting to realize that. I think we're probably in a place where at the height of COVID, we had an enormous demand for telehealth, and we actually started with basics like Zoom, like this meeting is. And we're looking now to hopefully get to a bigger and better platform that's a little easier to use with more options. But by and large, telehealth has transformed the way we do things. And I would argue at the height of the pandemic, 99% of my patient encounters were telehealth. Now we're probably closer to, say, 20%, 25%. And I'm hoping that will ramp up as people realize how convenient it is. So just that.
Great, thanks, Andrew, and welcome. And last but not least, Ankit, do you want to do the same?
Thanks, Jeff, for having me. Hey guys, my name is Ankit Bhatia. I am an Advanced Heart Failure Fellow and Innovation Fellow at Washington University School of Medicine in St. Louis. And so, being from an academic health system, our path was a little bit different when it came to virtual care. It had been something people had talked about for years and years, and then COVID happened, and that kind of pushed our hand a little bit. So it came about slowly with a couple early adopters amongst the attendings. And then as time went on, a lot of the fellows started to adopt it as well, to the point that it's really become part of our training and our outlook and how we consider future patient care when we're thinking about future encounters for patients. At first, I think it really took the role of like a substitute to an inpatient appointment. We're going to mitigate the risk of COVID by having you be seen virtually. And more, I think now we've become more sophisticated in thinking about it as how we can augment potential inpatient encounters as well, as opposed to purely just substitute. For a new heart failure patient, for example, considering how can we schedule a virtual appointment to help to up-titrate their guideline-directed medical therapy? Or for a transplant patient that is coming from far away, can we kind of schedule an appointment in the meantime to ensure they're doing well before their next follow-up appointment that was on the books? So yeah, I think we're just growing in our sophistication, but obviously a little bit slower coming from an academic standpoint.
Awesome. Well, welcome. Great to have all three of you. So we're going to get right into it. I want to make one call out to say for the attendees, we've had quite a few join. This session will take place over the next half an hour. And if you have questions, I'd encourage you to write them into the chat. And then I will serve as moderator to bring them in and ask various attendees, but please use the chat to ask any questions you have and we'll try to get through all of them. All right, so I want to start with a couple of the basics. I think this question in particular for you, Dr. Gomes, is how have you you've started to structure your day to bring virtual appointments in? Are you doing one day a week? Are you picking a time block? How have you seen that evolution, and has that changed over the past few months?
So the structuring of the telehealth patients, that has definitely changed over the time. At the beginning, when we had, there were about a solid month, we had 99%, say 99% just telehealth only, in which case it was a full blocks the whole day, and we only were seeing the emergent patient. As time went on, we tried doing a block, say half a day morning telehealth, the other half in person. Well, I think what has worked the best for me and some of my providers is doing a mixture in any particular session. So you have if you start in the day, the first 2 or 3 patients to be telehealth, and then throughout the day insert telehealth patients in between your in-person patients. Same for the afternoon as well. And the reason I found this to be very helpful was the early morning patients, you can start your clinic earlier that way, because your MAs or whoever is rooming your patients in can actually do that call the previous day and get their meds set up for them already. And they've already pre-told the patients, hey, when the doctor calls you, give them the blood pressure in the morning. So you're not relying on the MA's timing in the morning. And then having in-person patients with the telehealth, what that I felt was my timekeeping throughout the day it works out much, much better, meaning that our patient population, sometimes they arrive a little bit late. They take longer to room. But say somebody's still being roomed by your MA, I just jump ahead to my telehealth patient. Their actual appointment may be an hour ahead, but your telehealth patients are always happy seeing you earlier, or they're actually okay if you're running a bit behind. So they're flexible. And then you can still then spend the time on your in-person patients adequately and not feel rushed with them at all. That's been huge for me. So I actually start the day off with telehealth so that you can actually start the day a little bit earlier than normal even. And that helps with revenue cycle. And then spread the day out with mixture of both telehealth and in-office in any particular day. As far as how the day progresses in each visit, it really depends. Some patients who have done telehealth in a previous visit, it's very seamless. They know what to expect. But there are some patients, it takes a little while. I think patience is important, and also having some backups. If the device, the mode that you were going to plan on using, there's some hiccup, having some other options. I know Heartbeat is working really well, but if for any reason that doesn't work, can we use Zoom? Can we use FaceTime? Can we use Google Duo? Having those flexibility has also made it very seamless for me at this time.
That's great. And we'll get into rev cycle in a minute, but two follow-up questions to that are, how much training did you have to give to your staff and your team before you felt like your virtual side of your practice was fairly well oiled?
It really depends on what kind of app we were using. A couple of the initial apps that we were using needed the MAs to have longer conversations with the patients as to what buttons or things had to be pressed on their apps or their computer to make it work. So, but as we've used different apps, I think it's much more seamless. Now they know they just had to run through the medicines, make sure they're there, make sure that the patient has a set of vitals available when I call them or when my colleagues call them. So it's now well-oiled.
That's great. Now, Andrew, I think you're at a very different practice environment. How has your institution changed the way that it's structured your clinic and your outpatient visits? And what does the ideal setup look like there?
Yeah, first, I'm in an academic medical center, and as most of you probably know, the academic medical centers are largely risk averse. So we did our telehealth from the clinic to ensure uniformity and a bunch of other things. So, to me, a visit would be in person or telehealth. We'd have the same room, or we'd go to a dedicated room that had cameras and whatever, and go from there. Could that be more efficient? Yes, we're working on version 2.0. But basically, the way that I would do it is first, I tend to be the techie guy in my practice. So whenever someone has issues, I would be the one who would be the troubleshooting and the trainer and so forth. But by and large, basically, typically, the patient should get an email ahead of time with their link and time confirmation and all that. But of course, many patients don't know how to use email or don't check their email. And so many times I would call the patient, get them onto Zoom or whatever platform we were testing or using, join the meeting and have the meeting. The nice thing about telehealth, and I think most of my colleagues would agree, is that the visits are actually faster, right? Because you're not working on med reconciliation. There's no vitals assessment. The physical exam is limited. And for me, it's been a real, it brought back memories of what we all learned about the old doctor's visits, where you would go to someone's house with a little black bag and hope for the best. And now you get to really see inside people's homes. You get to see how they live. Is it clean? Is it adequately resourced? Who their support people are, if any. So a lot of additional information could be gleaned from the visits. And then I actually figured out, and Ankit will probably laugh, but from the heart failure standpoint, to have them show the camera on their legs and squeeze their legs and hold it for 10 seconds and see if I can see pitting edema. But it was actually surprisingly helpful, especially for those on diuretics. So for us, the greatest thing that occurred was parity, right? Which was the cost of the reimbursement for the visit was the same for telehealth as it is for in-person. The major downside of that, for those of you that have a facility fee, is you can't collect the facility fee because there is no facility, right? It's virtual. So our institution, had mixed feelings about telehealth, in that it enabled us to capture visits that we wouldn't normally have had because people were afraid to come in or didn't want to come in or whatever it was. But it also prevented the collection of the facility fee, which I'm hoping, as Medicare gets smart about this, will change the way we do things. But bottom line is, for us, the most efficient way to do it really was to have the MA pop in, get the patient on the telehealth while we were finishing up with our last patient, pop into the room, they're on the camera, we do our visit, and we would have another computer set up right next to the one where the video was on so that we could use our EMR and type while we're looking at the patient, which was actually kind of nice. So by and large, there's a lot of ways to skin the cat, so to speak, but there's a lot of efficiencies that can be gained when things are done well.
That's great. And Ankit, I'll get to you and particularly this question in the chat box in a second. But Dr. Gomes, I think how have you seen the rev cycle change with this? And has this been an effective way to improve or augment your revenue cycle, or is it's still preferential to bring patients in person?
I think I'm going to maybe answer that in two parts. I'm going to say during the COVID time, when we were overall as practitioners, we had less patients coming to the hospital, less procedures being done because of the restrictions of procedures, and overall less in-person patients. I think we as a group was able to maintain quite a good revenue cycle with the telehealth patients. And I think the patients that we were then seeing were not only the patients that we were due to see, but also some patients who were actually lost for follow-up. And there was actually the younger population. What I found with my panel of patients is there are some patients who are younger who normally would have to take time off work to come to a visit. And a 15-minute visit is never 15 minutes. They have the travel time, they have doctors running late time. So which would normally mean they were taking a half day or 2 hours off work. Now they were actually being able to see me in their break. They will, lunch hour, they will make the appointment that way. So we were seeing a lot more younger people coming. And I feel, and the other patients who were scared to come to in office because of COVID, I think we were able to see that population for the follow-ups. And I think we were, as a group, able to keep the revenue cycle steady during the pandemic. And I think moving forward right now, where we are doing both in office and telehealth, I think the opportunities are immense. I think it's immense not only to increase the revenue cycle, because you can give the patients this option of not having to miss work, not having to rely on another family member to bring you to the office, not having to rely on transportation to bring you to the office, and therefore keep their appointments. I think the opportunity is for us in cardiology to do better and better at our prevention of all the risk factors and catching things early, I think are immense. And I think that would be as part of the revenue cycle, increasing that as well.
Awesome. Agree completely, and that's really helpful. I think we've been talking mostly about the telemedicine component of virtual cardiology, but equally important, it seems, and frankly confusing, is the remote monitoring side of things and how to integrate this RPM, both from a standpoint of how you improve care, but also how you add that to your revenue cycle. So I want to start with Ankit on this because I know you've been heavily involved, particularly on the heart failure side of these this remote monitoring and care. One of our audience members, Bez Arkush, asks, how do you view home monitoring as part of remote treatment and prevention from rehospitalization? So I know this is an area you've worked in heavily, but how have you seen the strengths, but also some of the limitations right now of the state of RPM?
Yeah. So, I mean, this is a tough question because RPM is a little bit of a mess right now. There are a lot of various solutions, or like vendor-based solutions out there that kind of market themselves as home monitoring solutions. They provide scales, they provide blood pressure cuffs, some further sophistication beyond that, and they provide their own means of transmitting that information to hospital providers, who then can monitor that information accordingly. I think the issue that you face with that, first off, is that many of them at this point are not necessarily directly integratable with other existing technologies, including EMRs many times, unfortunately. And then in addition to that, it sometimes provides unnecessarily large amounts of data in patients that are otherwise stable. So I think one of the earliest questions you need to ask when considering remote patient monitoring is, do you want that data outside of a clinic visit or not? Because if you do, and you want that data purely to augment sort of the your clinical care in the setting of a clinic visit, that doesn't necessarily require a complete sort of infrastructure in place for someone to get alerts for various deviations from baseline and whatnot. And, so I think a lot of it has to do with patient selection. For those that are very high risk for readmission, it has been shown to be an effective tool to help prevent that with monitoring that is actually in real time or very close to real time. But I think that's sort of the big question that needs to be asked. In terms of how we're doing it in our practice here, we have a small subset of patients that we deem to be extremely high risk for heart failure readmission. And we've actually been using one of these vendors to actually monitor their heart rates, their blood pressures, and their scales, as well as some of their nighttime actually vitals using a bed monitor, under bed monitor as well. And any deviations get basically sent to a central RN within our heart failure practice, who then kind of escalates accordingly based on if they feel this is a real alert or not. That's been a very small subset of patients because that comes with a lot of associated cost and manpower. Many others, what we've been having them do is actually take logs. It would be great if there was a more sophisticated way of doing this, as Heartbeat Health and others are going to be rolling out. I'm not sure, Jeff, if that's currently a feature or a future feature.
Yeah, it's currently a feature. But,
okay, perfect. And I think adding that would be great to see that information, because otherwise you're dependent on patients taking that data themselves and then letting you know that. But I think really it comes down to, are you worried about this patient and their risk for readmission, or is it more to augment your clinical care in the setting of a clinic visit?
Well, and to that end, I would also point out, Ankit, for us, when people have come out of the hospital, if they call us up with a question or they seem confused, sometimes I'll instruct our staff, hey, see if this patient's willing to hop on a telehealth, and if there's a slot, I'll just connect with them and kind of get through their questions in person. So then it creates a billable visit, A, which of course everyone from the administrative side loves, but B, it provides incredibly good care. So.
And I think you've highlighted for me, Ankit, that RPM really is all over the place right now, and it's being used in many different use cases. There are many different versions of it out there, and I don't think the jury has decided yet what the right place for it to add value is or not, and that makes it difficult. So I think the setting-specific environments of how we implement and how we actually use various remote monitoring features matters a lot. And, the advanced heart failure clinic use is going to be very different than the general practice, private practice use. Dr. Gomes, are you doing RPM in your practice right now as a part of your billing cycle?
So we've talked to a couple of vendors, but we haven't really contracted with anybody. So we've really heavily been relying on the patient's own weighing scale, and majority of patients at some point or other have brought their blood pressure machines in-house and got it calibrated too, so we know what the numbers look like, documented in their chart. So we've been utilizing that. And then you had the patients with the heart failure patients with devices that are giving us the data from within about their volume status that we've been using more now than we were before. So that's been helpful as well. But this is something that we're hoping to get into, but we haven't as yet.
Great, and I think I've been hearing that a lot. We've certainly seen that a lot with a lot of our network cardiologists, and the addition of the fact that the rules are changing for RPM and how billables work and what the codes requirements are from CMS. All of this is a moving target, and I think it will be really interesting to see how it evolves and how it continues to be part of the care landscape, frankly, in the next 3 to 6 months. All right, excellent. So I want to shift a little bit in the last 15 minutes or so to what the future of virtual care is going to look like and what it should look like. I know this is something everyone has given thought to. It feels like we're in the middle of one of the transitions now, as Andrew, I think you said, you're at close to 99% utilization rates for telemedicine, now down to a quarter or less. What does the next 6 months, 2 years, and 10 years look like in your view of the virtual care landscape? We'll start with you, Andrew.
So for me, I think the virtual care landscape has a tremendous upside, and I'm hoping the momentum behind this lasts. The convenience factor, particularly in cities, Denver or New York, wherever you are, right? Who wants to spend time driving, parking, waiting for your doctor, whatever, when you can have it all very, very condensed and quick? It almost feels immediate in some cases. So I think there's that. But I think the future of the visit is going to be sort of an augmented reality type of thing. So imagine if we were having a visit right now, you could click a few buttons, use the RPM data available, see my weights for the last few months or the last few weeks or the last few minutes or whatever, my heart rate, my blood pressure, all these great things that, take a while to find right now in the clinic. And then I'm hoping that there'll be some intelligent assistance to the visit that will help to document. My greatest hope of all is that Heartbeat or somebody figures out how I can have a normal visit with you, be presented with all the data, have a normal free-flowing conversation, and at the end of the visit there's a note ready to sign that I didn't have to work on, right? Which would be amazing. And all the orders, of course, would be in because we spoke about, we should increase your carvedilol or your, bisoprolol, whatever it is. So, at the end of the day, my hope is that technology enables the restoration of the patient-doctor relationship in a way that is more than it was ever before. Meaning, we can have the relationship we had before where the doctor would sit right next to you and on his knee would have a little pad and write down whatever was going on, and then later on stick that note in the chart, and that was the day, right? I'm hoping something like that comes back. But I think that the greatest potential is really with technology, and I think the remote patient monitoring is getting so good with a variety of very small and inexpensive, waterproof, long-lasting battery devices. We can get the data we need to take care of patients very readily, very rapidly. And then most importantly, I'm hoping that the technology enables what I call the prevention of the data overload, right? The last thing I want is every heartbeat from every patient I had for the last month. It would kill me, right? Rather, I want the data that's important. Over the last month, patient's heart rate was 60, except on this day when they were in rapid AFib, and you need to do something about it. That's what I really want. So I'll let others share their thoughts too.
Yeah, that's awesome. And I just want to make two comments in follow up to that. The first is that I think one of the things you have highlighted, and we've talked a lot about this, is that the patient-clinician relationship, which I think is such this prized event in medicine and healthcare. A lot of people going into this telemedicine transformation over the last several months have viewed telemedicine and virtual care as detracting from that. And I think there is a large and growing group that's realizing that you can maintain that relationship with telemedicine. And in fact, you can use some tools to actually augment it. And you explained some, like seeing the home environment or being able to do some exam maneuvers, being able to add vital signs. I think to me, one of the keys to the success of this next phase of telemedicine will be really highlighting just how that relationship can actually be maintained and improved and embraced, rather than a subpar replacement of the normal exchange. And then I also want to highlight the prevention of data overload is something we have heard again and again and again. I think it is so important as all of us evaluate the various options for bringing virtual care into our practice habits and environments, is making sure that there's a preservation of what data is shown at the right time and how to use that to actually impact improved care, rather than just bringing a multitude of data points from all different sources and hoping that amounts to a clinical intuition that otherwise is not there. So I think that's a fantastic point. Dr. Gomes, how about you? What do you think the next couple stages of virtual care will bring?
I think I have to say ditto to everything Andrew just said. I think it cannot end here. I mean, our patients, they've got used to this. How can you have a 15-minute visit? It's due at 7:30. They get ready at 7. They're there. How can we turn the clock back? I think it'll be impossible for the insurance companies not to let the patients have this for their healthcare, both as an investment in the patient's future, for actually their well-being for the future to reduce the cost of patient care down the road. I think that's number one. I think number two, as Andrew was saying, we can see things that are sometimes difficult. For example, in the patients that come to the office, they might say, oh, I forgot to bring my bed list with me. With telehealth, it's been amazing. I just tell the patient, please go ahead and bring your bottles, and they line them up and we go through them. We go through, refills are done. There's no question about any misunderstanding of what they're taking. It's been a very helpful tool for the patient care for me. Overall, I think we're gonna benefit from short-term patient care, long-term of patients, getting pools of patients that we were missing out because they weren't able to come to the providers' visits because of transportation, time off work, needing a family member to come with them. All those things will not need to happen. Utilizing all the platforms that we can, and then using the data that hopefully, as you've talked about, that we can utilize in the visits, including even now some patients have their eye watchers and they have the EKGs tracings to show me. The visit, the one-on-one feel, I think I personally can still keep that going in two ways. One, if I have done an echo, I need to show them what the echo looks like. I use another monitor to show them what the echo, go through each as I would normally on a face-to-face visit in-house. And one way I have continued to face the patient and continue and the note to be ready virtually when I'm done is I've continued using my scribe during my virtual visits as well. They've either been, and my scribe works from home now because of COVID, but it's worked well and it's working well. And I'm able to keep the one-on-one. Patients don't feel like I'm looking at the chart and not at them. And I'm able to get those documentations of some other data into the chart with my scribe as well. So it's part way, not quite electronically in my chart, but somebody else is putting it in, but it's there by the time I'm done with the patient. I hope it does not go away. I hope it makes our patient care better for having telehealth visits. And even, I think both Andrew and Ankit said, we can utilize the telehealth for patient care, for immediate care, meaning that somebody calls the office, says, oh, I have this problem going, and there's this back and forth nurses visit. You can see it happening. It's so much easier to say, just add a telehealth visit. I have an opening, just add them, and it happens. So I hope it never goes away.
That's great. Thank you for that. One tactical question that comes from the audience is, what's the breakdown of using telehealth with new patients versus follow-ups? And I'll stick with you on this, Dr. Gomes. What do you think your breakdown is in your practice?
I try to do majority of my patients who are new as in-person. But if somebody wants, for whatever reason, of either they're still worried about COVID and they would like to see me as a telehealth, I do that. But then I make the next visit, it has to be an in-person. Overall, I feel my bonding with the patient and the non-verbal cues that I get from the inpatient first visit is there for me to get a sense of what's what. I feel that's important to my patient care. But through the COVID year, I have had numerous patients who had the first visit. And then what I followed that up, even if I've had a new patient visit on telehealth, is I will get them to come to the office for their EKG and their vitals within a very short number of days. Usually it's 2 to 3 days. And they'll bring their blood pressure machine if they have one at that visit. So I can thereafter manage them more appropriately, I feel.
That's great. And I think we've seen as practices begin to establish rules like that, which I think you're not alone in having sort of your own set of rules about who should start with in person or as I've started calling them, a terrestrial visit versus a virtual visit. And I think creating rules around that actually set up the practice to be much more efficient about that, so you can automatically know to then bring a virtual patient into the clinic for their EKG, and follow-ups can happen fairly seamlessly. So I think that structure has proved to be really helpful.
I think I'm going to add one more thing that would help me along the way. At the very beginning of when we had telehealth visits, I would be writing things down. Okay, for this patient, I need to let so-and-so, something small that they need to follow up on, or order a CT just to make a follow-up. I found that things sometimes went off, got lost. So I make it a habit now. After every telehealth visit, I sent like a special note via the EMR system to the MA post telehealth visits to dos. And it can be as simple as please mail the instructions, mail the lab slips, or specify, CTA, whatever test, not the in-house testing, but there's some testing that we don't do in-house. So for example, somebody needs a CT of the aorta, somebody needs a referral to a pulmonologist. Those that are outside referrals, I now document so that the MAs have to sign off on it and nothing gets messed up.
That's great. And I'm going to stick with you for one more follow-up question that we just got in, which is, across your practice, what's been the level of engagement on the physician side? Are you finding that there are hesitant or resistant physicians to doing telehealth, or are you getting uptake across your practice?
At the very beginning, there was definite resistance from some of the physicians, but as time went on and when the physicians could see the benefits of telehealth and how learning, we learn from each other, what the workflow, what works, what the issue that somebody was finding difficult to do during the visits that they've done and how to work around it. I think it's been a stepwise progress over the last several months, but I think we've come to a state now where I'd say all of my physicians are comfortable doing telehealth. Are some of them more comfortable than others? That's a definite yes. But I think it's definitely everybody, if they need to do telehealth, they would. But
Great.
Long term, I think some would be doing it more than others.
Great. Very political answer there, which we agree with. All right, so Ankit, I'm going to finish with you. You get the same question about where's virtual care headed, but also a bonus question, which is, you're, I think, wrapping up your career as a fellow and moving into your next stage of practice. And I'd love to hear how virtual care and this landscape has informed as how you think about the next stage of your career and what you've chosen to take on as you embark on the next stage.
Yeah, so just reiterating exactly what Reshmaal and Andrew both said, really this whole COVID period has brought virtual care to patients. And especially if we think about sort of the millennial generation and whatnot getting older, they're going to want healthcare brought to them. And I think it's going to be very difficult to come back on that relationship now that it's been introduced. In terms of things to look forward to in the future, most of the stuff has already been brought up, but the one thing I would add is that right now with remote patient monitoring, we have a lot of different data streams. Andrew had brought up, iWatches, and many folks have ICDs that have both heart failure and arrhythmia related monitoring. I think a capability I'd like to see is those be incorporated into a single place that would easily interpretable. Because I think we have a ways to go for RPM to become predictive, but for that to be the case, it's gonna have to involve integration of these various technologies. And at first, if we could just see them without 1,000 clicks in various places, that would be a good start. And then in terms of future career, it's just been so interesting because it took a while for virtual care to pick up at our institution, but actually it has now become part of our core curriculum for fellows to become competent in virtual care. And speaking for myself, I'd say that my viewpoint of how I approach patient care is, do I want to see this patient virtual or do I want to see them in person? And a lot of that just depends on so many various things. So I think now the mindset of trainees coming through are going to be that virtual is part of their repertoire of how to treat patients. And as time goes on, I think practices that incorporate these physicians will have to kind of adjust accordingly.
Excellent. Well, that's fantastic. I agree. I think in much of the work that Heartbeat and the ACC are doing together, we agree that the future will have standardization and credentialing pathways for virtual care. And this is really just the beginning of how we establish that integration into the normal workflow. So I want to thank everybody so much for joining. I'm going to finish with a prediction that was nicely asked by one of our attendees, Thomas Johnson, which is what % of visits do you predict to be virtual in 2 years? We'll follow up and have a repeat panel in 2 years, and whoever gets the closest, I suppose, will get one of Andrew's virtual cardiology augmented reality headsets. So we'll start with you, Andrew. What % of visits in 2 years do you think will be virtual?
Well, you could answer that question in what % I want to be virtual. I think what % of visits will be virtual is probably still going to be about 25%. My hope is that it's 50-50 or more, but we'll see.
Great. And Ankit, you're next.
So I think that the denominator is going to go up as as Reshmaal and Andrew were both referring to, those nursing appointments that kind of go back and forth over and over again, as those become more virtual. So I'm going to say 50%, but with the same amount of in-person as we have now.
Excellent. And Dr. Gomes, last but not least.
So I'm going to say in an individual provider's practice, I would personally love to see about 40% telehealth and 60% in person, but I don't think it's going to go that. I think it'll stay around 15-20%, sadly, but I will love to see it go up, but we'll see.
Excellent. Well, we shall see. We'll bring everyone back. This is recorded, so your guesses and numbers are locked in forever. Thank you so much. First to the panelists for joining us, Andrew, Reshmaal, and Ankit. A pleasure chatting with you. Really some amazing points brought up today. Thanks to all the attendees for coming. We look forward to putting on more and more of these webinars, and really pleased that there's been such an excellent attendance. Have a great night, everyone, and keep pushing that virtual cardiology.
Take care.